stimulants right at the top. Hallucinogens, not very much addictive potential. They don't cause much of a flood in the nucleus accumbens. So the theory is that instead of eating, drinking, making love, which are the natural stimulants for your nucleus accumbens, the drugs tell you that you need to take them in order to survive. The repeated use of the drugs or alcohol saturates the brain's reward pathway. The person can become conditioned to an intense level of stimulation. Okay? The normal levels of natural rewards no longer feel as pleasurable. Okay? Because again, especially with the stimulant drugs, if I'm using stimulant drugs, my brain is hugely compensating by pumping out a whole lot more neurotransmitters that's sedative in nature. Okay? So if I'm not using the stimulant drugs, I'm not at the level, I took it out there, when I'm not at the level brain level anymore, I'm low. I'm feeling a little depressed, I'm feeling a little numb, I'm feeling a little dead, because my brain has compensated in that downward selection. And then after chronic use, the reward pathways, the neurons are so depleted that nothing is pleasurable, not even the drugs. We had one study that was done with, actually with heroin addicts. And they brought them into a closed hospital setting because they wanted to see what the top level was on tolerance, what was the ceiling on the tolerance that people wouldn't go past. Because even with heavy nicotine addiction, you generally don't see people who can really tolerate smoking more than 3 packs a day. With caffeine, with alcohol, let's see, if alcohol, if the legal drunk is 0.08, right? So close to 1, close to 0.1. We see people walking into the treatment centers at 0.475. So about four times the legal drunk level. We don't see people generally over that. I've never seen anybody over 500. So 5 times the original intoxicating level is kind of the ceiling on alcohol. When they brought the heroin addicts in, these were heroin addicts who were clean. They brought them into a locked setting, and they said to them, you can have an injection of morphine anytime you want it. And we will give you as much as you want. You come and tell us the level. And these are all street-savvy heroin addicts. So they started out with small levels because they're not going to overdose themselves. They haven't been using for a while. So they started with small levels of morphine. When they finally stopped the experiment, because the morphine didn't look like it was going to stop on its own, one addict was taking 10,000 times his original dose. Now, the reality was, at 10,000 times his original dose, he wasn't experiencing pleasure. He was now only medicating to not do withdrawal. And at that level, at those really high levels, the addicts who were using at those really high levels, they didn't look like they were nodding out, spaced out on narcotics. They looked more like, actually like methamphetamine addicts. They were paranoid, they were pacing, they were agitated. So the brain had compensated in terms of the tolerance, but there seems to be no ceiling on tolerance for the opiates. That's why if you're a nurse working in the hospital, you know, you have a patient comes in, say with a fracture of the femur. On the first day, you might give them maybe Demerol 100. On the 7th or 8th day there, when they're telling you the pain medication doesn't work, they're really telling you the truth. Because over time, the body has, from the very first injection, started to adjust to the level of morphine. So sometimes we're so afraid of addicting people in the hospital, we're not considering the fact that their body and brain are adjusting. They may not all be becoming addicted. In fact, addicting people in the hospital is very, very rare.
1%?
Yeah, very rare. Yeah. The people who become addicted from, addicting drugs in the hospital from pharmaceutical drugs generally had a genetic predisposition to begin with. So I'm going to let Brett take over here. Now we're going to talk about where you're going to work and how that increases your risk of becoming addicted. I'm writing.
You want me to fly?
I want you to fly.
All right.
I'll jump in if I want to contribute anything else.
My name is Brett Barker. I am a registered nurse, and expected to be the caretaker for the longest time, getting out and giving of myself without getting any reward back is almost like chasing a high for me. I always wanted to be the best. I want to be a perfectionist. I don't know about you, but when you got this test coming up, bet y'all want to get 100%, if not 101, if it's at all possible. And you want to be the best you can because you want to be able to get good grades. So when you walk into the room in the hospital and the situation approaches itself to you, you want to know what to do, right? You want to be the caretaker. You want to be the person on the spot. You want to be the go-to person. And you want to be trusted, respected, and have people come to you. Am I correct in that assumption? Okay. So you're expected to be the caretaker. A lot of that expectation is internal, as I found for myself. And other people expect it.
Double shifts.
Double shifts. I hear Sharon say all the time that if all the nurses in this valley got well and would take care of themselves first, we would need a lot more nurses. So that would help with our job security because we're going to jump and we're going to run abnormal working hours in the shifts. I don't know how many times, I get the call, it's my day off, can you come in? And it's not even my shift, so my sleep-wake cycle is off, and I'm going to jump in and go. And it's really not about the money. Even though the money is good, I want to be there, I want to fill in, I want to be a part of, and I want to support my team. And then I'll sacrifice my family time. Right? So I will give that up to go to work because they need me. My family's okay, and they need me. So off I go running to take care of that stuff. It's also hard physical work. Now for a guy I've had a long history of back problems to start with, I see some rather small statured people in here, and that's not the stereotype or tuck down or anything. However, if you need something, who are you going to go to? You're going to call him or you're going to call me? Right? Well, even if not, you probably call us both, right, to come turn your 450-pound patient. And the fact is that with 60% of the population in this country being overweight, 30% of them being obese, and that 60% number going to 75% in the next 10 years, we are taking care of some large people.
Anybody here already working in hospitals? Huh? In clinical? Did they tell you about the no lift policy? How's that work? I bet it works better when you're a student nurse than when you're actually out there. What's the no lift policy say? Anybody know?
I don't think all hospitals have that.
Oh, interesting.
Yeah, and they don't all have lift teams, and so.
Yeah, the whole thing was, what Brett said, trying to help the nurses, trying to cut down on back injuries, mainly that's the biggest complaint for most nurses. They instituted no lift policies, which means no one is to attempt to lift a patient by themselves. You're supposed to call the lift team, call somebody else. Well, at 3 o'clock in the morning, how's that work?
It doesn't work. I mean, I started out as a CNA and an LVN working in skilled nursing. If Sharon's down on the floor at 3 a.m., I'm going to be there. Or if I'm in the bathroom and I'm helping put a new brief on her and she's standing on the rail and she starts to go to the floor, I don't have time to say, hold on, I need to get the lift team to come in and help me. It's just not reality. But legal protection, so they don't have to pay workman's comp claims or whatever, we have this aura that it's a reality. Right? Because it's put in a procedure, it protects the facility. And a lot of things are like that. When it comes to healthcare versus any other industry, so I see a lot of young people in here. I don't know how much experience you have in other industries, but healthcare is like its own little world. And it has a hard time looking at, like with information technology, it has a hard time looking at big business and saying, yeah, that's going to work for me. They got to recreate the wheel in a lot of ways. So there's a lot of hypocrisy, but I'm not going to get into that. Difficult mental work. So we're always on the go. We're doing the multitasking in our brain. We want our brains to know. We want our coffee. We want our chocolate. We want the donuts at the nursing station. And I don't know about you, but I want to be able to get it done, get it figured out, get my tasks accomplished, do it very well, and move on to the next thing. And go, 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 go. I can really pass the day really fast, but it is difficult mental work. If you look back on your basic physiology, your brain just runs on glucose, right? So you're just burning through sugar left and right. And that takes away from our physical ability to do stuff. So we get tired. We get tired to the point where we can't sleep. And for me, so there we go into the other things that may not be street drugs or prescription drugs, such as Ambien, but I know a long time ago, I take a couple of Benadryl every night, Tylenol PM. Readily available over the counter. They got a whole section in the pharmacy. It's not one box on the shelf, but it's a whole section. Right? Need something to help me sleep because I got to be up in 6 hours.
Yeah, jump down to number 13, because I think that's what you're talking about.
Acceptance on some level of the right to self-diagnose and self-medicate. Absolutely. So with all the knowledge that we work with our patients, plus seeing how they react when I give them the shot of morphine or I give them a sedative or anything like that.
So let me keep your instructor out of the room for a couple of seconds. We'll do a little experiment here.
It doesn't hurt me every time.
I know. Well, you don't have to take all your stuff.
Oh, it's all right. Last time I was out there for a while.
So one of the reasons that I'm here today, in addition to the other things that I told you, is that I am a recovering addict. I'm a recovering Demerol addict. Okay, I was arrested at O'Connor Hospital about 29 years now, 30, for stealing Demerol and using it for myself. So I talk from a point of personal experience here. So as we're talking about this, the difficult physical work and mental work and the taking the Tylenol PM. Did you all know that that's why Tylenol PM works? It has Benadryl. Yeah. If you're not having any pain, don't take the Tylenol. It's right after your liver, just take the Benadryl. Okay, so here's the little test. Has anybody in here? You can just raise your hand. That's why I threw your instructor out. Anybody here ever come to class sick or hurt? Sick, got cold, you got allergies, that kind of stuff. Have you ever gone to a clinical sick or hurt? Because if you miss one of the clinicals, if you miss more than 2, you're out that clinical, right? Okay, so how many of you have gone to a clinical sick or hurt? How many of you have missed a meal to study? How many of you have missed irregular sleep to study? How many of you, with the illnesses that we talked about, cold, I feel like I'm coming down for cold days, have used an over-the-counter medication to kind of diminish your symptoms so you can be here not sneezing on everybody? So I will tell you that in terms of the curve of addiction, to the point where I am now stealing drugs from the hospital to self-medicate, if this is the slide into addiction, down here, you know, I'm stealing drugs, I'm self-medicating, we go back up the, and down here, now I get arrested. Nothing that we ever want to have happen to anybody in this room. If we talk about this as the slide down to addiction, we're not talking about you guys getting there someday. You're already on. You're already on. You're already deciding that something is so important that you're going to go even though you're hurt or sick. And you believe so much that you know yourself, you know your own body, that you'll self-medicate to go to this important thing, sick or hurt. And I will tell you that of all the addict nurses that I've dealt with over these past 30 years, this is the pattern. This is what we're talking about, both on this slide and when we get to the next one, about how we invest so much of ourselves in the job, in our coworkers, because you become like a family, that you hate to call in sick. What happens when you call in sick?
Oh my goodness. Just the guilt of calling in sick. Sometimes, in recovery, I have to call in sick just on purpose to try to feel better, but it's just not an option.
Yeah,
I
calling
feel
in sick and your coworkers.
And they can't help it, not intentionally putting the guilt, but you hear it in their voice, oh no, I gotta get somebody else, and blah, blah, blah. And then that guilt takes later, and I'll do 2 extra shifts and I get better.
Yeah.
To try to make
To
up
make
for
it
it,
up.
and you can
Yeah.
never do it.
Or you call in sick, and what I would get when I was calling sick, I'd call the staffing office, and they would say, How sick are you? Could you possibly come in for half the shift, and we'll bring somebody in early from the next shift so that you can go home? You weren't actually throwing up on the patients, they wanted you there. They wanted you there because staffing was usually that short, especially staffing the people who knew the unit. Because if I call in sick and they bring somebody from float pool or temporary, from the temp agency, it was utter chaos. Now, when I worked at O'Connor, the unit that I was arrested off of, it was a 42-bed post-surgical ward, so not the recovery room, but the post-surgical ward. 42 patients, and our staffing one night was 2 RNs and 2 aides. So as one of the 2 RNs, I had either 20 patients if I was on the west wing, or 22 patients if I was on the east wing. So a lot of the stuff that you see here was so prevalent in terms of my giving my energy and all to the hospital. Go ahead, Luke. We'll get your instructor back here in a second, because I want to talk about marijuana before she comes back in. I want just all to be able to be honest here. That's one thing you need to know. Nothing in this room goes out of this room. So you can be free to talk in here. You might not want to share something with your co-students, but if we talk about it just in general terms, if we're talking about this, medicating yourself at school, or talk about marijuana, that's not going to go out of this room. Go ahead. Where are we at? Being in control.
Yeah, we're being in control. So on the backside of that, calling in sick and stuff, after being in the facility and doing it enough, when you're asked to come in for and you can't, they're asking me to stay. And I usually will. So it goes both ways. Because, back to number one, we're expected to be the caretaker. We set really high expectations for ourselves. Now, the element of being in control, we have talents that we're able to develop, we're able to run, we're able to do all these wonderful, beautiful things, and we're going to believe that when we have, because I work in intensive care, when I have the patient on the ventilator, on 12 different IV medications, with a rectal tube, a Foley catheter, a couple of chest tubes, and nobody else is there but me, I'm feeling like I'm in control of the situation. And all I'm really doing is utilizing knowledge and skills and things that I've learned to do that. But you can't help but, as a human, feel like you're like this God. It just kind of comes.
And the day the disease comes in you, because one of the prime psychological defenses for the chemically dependent individual is the belief that they're in control. What does an alcoholic say if somebody confronts him about the drinking?
I can stop anytime I want.
Why are you making such a big deal? I could stop, I could change. I believed that I was in control. I kept saying to myself, I know this. It's not that I didn't know it was wrong. Of course I knew it was wrong. I'm self-medicating. I'm self-medicating pain. I'm self-medicating an inability to sleep so I can be at work. I knew it was wrong. But I kept saying, if I ever see any signs that I'm becoming addicted, I'll stop. Well, stealing drugs from the hospital might be the first sign that you're addicted, okay? At the end, I believe I was using about 1,500 milligrams a day. Now remember this no ceiling on tolerance for the opiates? You need more and more and more every day. Anybody in their right mind, and that's the real key, would see that I was addicted. But in my mind, I was still in control. And I was going to get it in control, and I was going to stop using, and then nobody would ever have to know that I had done this sort of awful thing. The alcoholic addict brain is not processing healthfully. And this is at a time where I was the charge nurse, I was the resource nurse for the preceptor for the new RM1s that came in. I was on 5 different committees in the hospital. So in terms of functioning, I could function. But in terms of making decisions about myself and my own addiction, total inability to do that. Because I believed I was still in control of the whole process. Because the minute we admit we're not in control, it's devastating. It's devastating because we have to believe, as a nurse, as you say, you face all of these horrible situations in the hospital. As a nurse,